for this potential FCR group with mutated IGHV, it's really very important to consider getting FCR as upfront therapy because this may be a chance at cure. And in any case, it's a better than 50-50 chance of being in remission for over 10 years on no further therapy, which is really very appealing compared to being on chronic therapy for all that time. And with the kinase inhibitors, we don't know actually the durability. We don't know what will happen when one's been on them for 5 or 8 or 10 years because we don't have that length of follow-up. So it's very important to find out your mutated or unmutated IGHV status as you consider first-line therapy, especially if you're younger and don't have many medical problems. Now, for the older patient subgroup, or those who have multiple medical problems, it's a little bit more complicated because it was never found that fludarabine-based therapies were any better than the older drug chlorambucil. So most of our studies of chemotherapy for patients in this group have used chlorambucil as a basis. And now the most recent studies showed that adding a new antibody called obinutuzumab, which is also targeted against CD20 like rituximab, but is a newer drug which is more potent in CLL. Obinutuzumab with chlorambucil actually results in a median, what we call progression-free survival, namely alive and still in remission, of 31 months, and people don't need treatment again for over 4 years. And this is for really what is a very benign 6-month therapy. So who should consider that? So for patients who have low-risk disease, like mutated IGH, who don't have any high-risk chromosome abnormalities, like 17p or 11q, and who would like a time-limited therapy rather than potentially indefinite therapy, it could be quite reasonable to consider a short course of this chemotherapy and then hopefully get 4 years or so without needing more treatment, rather than committing to ongoing indefinite kinase inhibitor therapy. For people with higher risk CLL, the 17p or 11q deletions, or the higher risk unmutated IGH, it's a little bit less clear that going with the chemoimmunotherapy would buy as much time before having to start on a drug like ibrutinib. So for those people, it would be potentially more relevant to start on ibrutinib sooner. If one does start on ibrutinib, one needs to be aware of some of the chronic side effects that develop over time, and these can include swelling, aches and pains in the joints and legs, which can be quite irritating. There's some diarrhea and muscle spasms. And there are some medical problems associated with it as well, about a 5 to 10% chance of a heart rhythm abnormality called atrial fibrillation, and some incidents of bleeding, most of which is just easy bruising, but which can occasionally associate with more significant bleeding. So in summary of who should get chemotherapy in CLL, fit young patients who have favorable mutated IGH and low-risk chromosomes clearly should get FCR in an effort for what appears to be even potential cure with a 60% chance of long-term remission. Beyond that group, a value judgment is really required as to whether one wants to do a fixed duration of therapy for some number of years off therapy, or to commit to ongoing chronic therapy, which may have some ongoing chronic side effects, but will likely control the disease for an extended period.